Hello, this is Jeff Lighthall. This is going to be a talk on the principles of resuscitation, which is going to be an introduction to a couple talks that follow on the use of fluids and decisions on whether to use inotropes or vasoconstrictors in resuscitating your patient. For the purpose of this discussion, it's important to point out that by resuscitation, we're not talking about CPR and ACLS. So this is not about compression and ventilation ratios, but more or less trying to bring your patient back from the brink of organ dysfunction in what might be termed a shock state. Prior discussions in this series highlighted the importance of two relationships in defining whether a patient's current physiologic state is consistent with shock or likely to develop into a shock state. The first relationship is pretty familiar, and that's the relationship between organ blood flow and current blood pressure. And as described, if you are in this range here, the flat part of that curve, then your body is perfectly good at maintaining very constant blood flow through your end organs without any disruption in blood flow or cellular health at all. So everybody's blood pressure is a little bit different. Some people have curves that are right shifted and other people are pretty normal like described on that curve. But the bottom line is if you're at this lower portion of this curve below this shoulder or inflection point there, you're subjecting your organs to blood pressures that are below what they're used to. And it's unlikely that that organ is able to distribute blood flow throughout that organ in a manner to maintain cell health. And indeed, this would define someone's blood pressure as being in a range that would render that patient in shock. The other relationship that's very important is the relationship between oxygen consumption and oxygen delivery, or so-called the supply-demand relationship, V.O2 and DO2. As you know, oxygen delivery has two components. One is the content of arterial oxygen, and the other is cardiac output. And just to be complete, we'll map down into cardiac output times SVR. The content of arterial oxygen is largely described by the hemoglobin concentration, and assuming that you're able to keep the saturations above 90, that's really the main component, hemoglobin and cardiac output. So again, there's a flat part of this curve that describes a patient in good health. And normally, if you have oxygen deliveries that are at least twice of what's being demanded or consumed, and these are all the same units, this is mils or liters per minute of oxygen. So really, if you're above this point here on a given curve, you're fine. As you creep down into the supply-dependent regions of the curve, your body does not have enough oxygen to meet its ongoing demand, and therefore anaerobic metabolism will supervene, and your energy yield will not be as great as with aerobic metabolism, and your cells become subject to damage. With this framework in mind, it's pretty easy to see how the different types of shock states play out. Distributive shock is characterized by patients that cannot maintain normal vascular tone, be it from a spinal cord injury or more likely from an inflammatory condition, either endogenous such as pancreatitis or allergic, or something related to an exogenous insult such as Legacy medicines and anaphylaxis are like that, but septic shock and our responses to pathogens are pretty characteristic of that. Because we cannot maintain vascular tone, we are in the lower part of these curves here and subjecting those organs to inadequate blood flow and dysfunction. Cardiogenic shock manifests itself in a decrease in cardiac output, which starts sending you backwards down this curve in that direction. Because the vasomotor system is largely intact, a lot of patients with cardiogenic shock have very high vascular resistances and are able to maintain blood pressure mostly within their normal range, whichever curve is applicable. and sometimes just barely, but many times you see patients who are in horrific cardiogenic shock and they have a MAP of, say, 60 to 65. The problem is it's all from vascular tone, not from cardiac output. And when you look a little more deeply into their metabolic state, you realize that they're down here in that part of the curve on the V.O2-DO2 relationship. Hemorrhagic shock and hypovolemic shock have a similar profile in that in the case of hemorrhagic shock, you're losing hemoglobin as well as preload. And so again, you might be traveling down in this direction here, and you might have a very normal blood pressure, albeit maybe a little bit tachycardic as you are trying to compensate for the low vascular volume and low cardiac output. So this covers the prototypic shock states, cardiogenic, hemorrhagic, and distributive, and shows where those might manifest themselves on these key physiologic relationships. So if you buy the line that the root of all evil when it comes to shock and organ dysfunction is being in these lower parts of these two curves that describe key physiologic relationships, then perhaps the root of salvation is moving in the rightward direction, both of those curves, and making sure that you're landing on a part that the body considers normal. And indeed, that underlies the principles of every resuscitative strategy that's been described and published. And that will be the subject matter of some of the follow-up videos on fluids, inotropes, and vasoconstrictors. But just to set the stage for things to come, the one thing that you will notice in both of these relationships is the common factor of cardiac output. And so whatever you do to improve cardiac output will send you in the correct direction on both of those curves. The caveat is if you see you have a very low blood pressure, you might decide, okay, this is something that I'm going to remedy by increasing vascular tone. And indeed, you might actually achieve normalcy in one of these curves. But if your cardiac output is very sensitive to that vasoconstrictor, you might actually be going in the wrong direction on this curve here, especially if you have a problem that's not only related to vascular tone, but compounded by low intravascular volume or bleeding. So that's the shape of things to come. So to summarize and introduce subsequent topics of exploration, the tools of the trade really come down to assessment of fluid status and understanding whether the patient's fluid responsive and whether they're fluid tolerant. That will dictate what you're doing with fluids. Secondly, it's important to have some idea whether the patient is one who's going to respond to an inotrope, and most inotropes are chronotropes, so we don't really consider that a distinct category. But distinguishing somebody who needs an inotrope versus someone who needs a vasoconstrictor versus someone who might need both, that rounds out the picture of resuscitation. And if you can use your various monitoring modalities to answer these questions in kind of a flexible manner, because sometimes some modalities are more appropriate than others, but if you can use those all in a flexible manner and get back to these fundamental questions and then ask yourself, am I going in the correct direction in both the V.O2-DO2 curve and the blood pressure autoregulatory curve, you will be a successful resuscitationist. And being successful is nothing more or less than just mastering this material. Thank you.